أكل كتير، رغي كتير، شغل كتير، انفلونسرز كتير، جيمز في الحمام، هاي سكور، تلفزيونات في الجيم، مابس في العربية، سكرينز. بنقضي نص اليوم باصين على سكرينز، وده ممكن يأثر على العين ويسبب لها جفاف. استخدم بولي فريش قطرة لجفاف العين وخليك في البيت. أكل كتير، رغي كتير، شغل كتير، انفلونسرز كتير، جيمز في الحمام، هاي سكور، تلفزيونات في الجيم، مابس في العربية، سكرينز. بنقضي نص اليوم باصين على سكرينز، وده ممكن يأثر على العين ويسبب لها جفاف. استخدم بولي فريش قطرة لجفاف العين وخليك في البيت.
Bismillahirrahmanirrahim. It is our pleasure again in City Eye Center and the Jordanian Ophthalmological Society to continue our educational webinar. This night we will be with a distinguished speaker, Dr. Samer Kharma. He will be talking about improving our practice in oculoplastic surgery. Dr. Samer is well known in Jordan and in the region, but I'll just remind you that he's a fellow of the Royal College of Surgeons. He's a consultant oculoplastic surgeon in the private sector, and he's a visiting consultant in King Hussein Cancer Center. Welcome, Dr. Samer, and you can start.
Thank you, Dr. Ibrahim. السلام عليكم، مساء الخير جميعا. الصوت واضح ان شاء الله؟
ان شاء الله.
الصورة هاي ده بلش البرزنتيشن. سكرين شيرنج واضح يا جماعة؟
100%.
تمام. بسم الله الرحمن الرحيم. وكل عام وانتم بخير. انا عارف الناس يمكن مرهقين صاروا من كثر الويبنارز، بس احنا يعني continuous medical education. أنا بدي أشكر شركة أوركيديا على sponsoring this activity for their great efforts to make it a success إن شاء الله. بدي أشكر برئاسة أخونا الدكتور إبراهيم سعيدات for his tedious efforts to make this a success. وبشكر جمعية طب العيون على دعمها الدائم. Today I will talk about some of our audience might be non-Arabic speaking, so I will speak in English. In fact, I will talk about some collection of topics related to oculoplastic practice. I made a collection of various topics. I squeezed my mind to talk about some of the most common oculoplastic surgeons which we see in our clinics, in general ophthalmology clinics. I will revise some of the basic concepts and tell you what I feel is an ideal practice in this issue. Dr. مركز المدينة, شكرا, City Eye Center, thank you. I will revise the main headings in oculoplastic surgery, which are the eyelid, the lacrimal, the orbit, the conjunctiva. I will talk quickly about some of the most common problems we see in clinics. I'll give basic messages which might be useful to anybody, I hope, to everybody. Talking about eyelid malposition, starting with simple problems. Eyelid malpositions, ectropion and entropion. These are frequent and frequently mismanaged, in fact. So I will just give few messages, hints about how to approach these common simple problems. First thing is, you need as an ophthalmologist.
دكتور سامر الميكروفون شكله بيشوش شوي، ما بعرف. Sometimes.
اوكي تمام.
هيك تمام.
هلا اوكي هلا انا بنقرب الميكروفون.
ممتاز.
Is it better like this؟ ممكن نغير السبيكر احنا.
This is okay now.
Okay. Okay. A proper assessment of type of eyelid malposition, ectropion and entropion, you have to decide. Is this a senile or a paralytic or a cicatricial problem. You cannot solve this eyelid malposition without categorizing it. What is going on? Is it a senile process or paralytic or cicatricial? So we have prepared questions to make everybody attentive and to give it more fun. So question number 1 for this case. خليهم يشوفوا السلايد بس أول منيح يا دكتور محمد. شيل السؤال بس عن إذنك شوية شيلوا البول number 1. Okay. Now this gentleman, he has quite marked right lower lid ectropion. So the question is, the cause of ectropion here is, now with the SL poll please.
نزل بول والله.
تصوتوا هلا بدنا تصويت. بدنا نعطيكم 30 seconds. The cause of ectropion here is cicatricial, mechanical, involutional, paralytic. Answers, please. Absolutely, absolutely, beautiful, beautiful. That's the truth. This is involutional, senile ectropion. You cannot address it as cicatricial ectropion. You need to know why this gentleman is not surprising in old people to have with this massive horizontal lid laxity, lax lateral canthus, lax medial canthal ligament. So you fix the medial canthal ligament, you fix lateral canthal ligament, and your problem will be finished. I'm sorry. Okay, here you go. We fixed his medial canthal ligament and we did lateral tarsal strip, and here you go, the gentleman before and after. We did the lateral tarsal strip, one of the most beautiful inventions in oculoplastic surgery, fixing the tarsus to the periosteum and bringing it to its youth and its strength. Now, this is a different case. This is a bilateral lower lid ectropion. Question number 2, the cause of ectropion here is cicatricial, mechanical, involutional, or paralytic. Now I'll ask the poll, please. Okay, let's see the answers, please. Excellent, excellent. Okay, beautiful. So my audience here is very much oriented in oculoplastic surgery. This is bilateral cicatricial lower lid ectropion. Typically, this takes place in cicatricial skin diseases like scleroderma. Usually, we need to refer them to dermatologist before doing anything. And if the general health is fine and there's no role for systemic therapy, then we go for lower lid skin grafting. Usually we bring graft either from the upper lid or from retroauricular area behind the ear or from the inner arm accordingly. We decide in each case. For example, this child, Bern case, upper lid cicatricial ectropion, as you can see with lagophthalmus, he doesn't close his eye. So we placed a skin graft. We took it from the inner arm, and this is how he looks now after the graft. Excellent closure. Move, as I said, that we will talk about variety of topics with messages here and there to make our oculoplastic practice ideal. Moving to ptosis. Ptosis is also a common problem in oculoplastic clinic. The most important and vital thing is you should never treat ptosis as an isolated lid problem. Ptosis belongs to this gentleman's orbit, which belongs to this gentleman's body. So before deciding that this is an isolated lid problem, make sure that his ophthalmic status is fine. He doesn't have a tumor. He doesn't have a muscle problem. He doesn't have any anomaly within the orbital area. Then, if everything is fine, you have to consider whether he has systemic problem, especially in acquired ptosis. You have to be very seriously concerned when recent onset ptosis. You might be dealing with a very serious life-threatening problem like myasthenia gravis, surgical third nerve palsy, Horner syndrome. All of these are life-threatening, potentially life-threatening problems. or you might be dealing with a pure ophthalmic problem, which is not only an eyelid problem. So you have to address the orbit and the eye as a whole, like in chronic progressive external ophthalmoplegia, like in third nerve palsy, like in mono elevation deficiency, double elevator palsy. You have to solve the problem from the roots, or you will never succeed in finding a solution. So question number 3 is, this needs more time, Dr. Muhammad. Life-threatening, painful third nerve palsy with pupillary affection. Again, every word counts, especially residents. Please be cautious in the exam. Every word counts. Life-threatening, painful third nerve palsy with pupillary affection is due to which of the one of the following? Which one is the cause? Life-threatening, painful third nerve palsy with pupillary affection. Paul, please. Excellent. So, what's the answer? Okay, give them some time. Give them some time, please. Life-threatening, painful third nerve palsy with pupillary affection. Answers, please. Okay, excellent, excellent. Great job. Great job, yes. Life-threatening, painful third nerve palsy with pupillary affection is due to this thing. Peak aneurysm, posterior communicating artery aneurysm in the circle of Willis, which is a life-threatening problem. If you fail to diagnose this problem, the gentleman next presentation will be a deep coma. He will develop subarachnoid hemorrhage. So there's a ringing sign. He visited the ophthalmologist, careful ophthalmologist, seeing a painful third nerve palsy with pupil dilatation, would really consider this problem. So he will do proper, he will take care of him, either do an imaging. The best imaging to diagnose aneurysms is CTA, nothing like MRV or MRA or CTA. A CT scan angiogram is the modality of choice, non-invasive, or he will need an angiogram proper through the femoral artery. You will send him to interventional radiologist. I would either refer him to a neurologist to take care of this responsibility, because there's a life-threatening problem. Moving to another topic, right third nerve palsy now, still within the same topic. I want you to observe this gentleman. This is when this is in the looking at the primary position. He has a right ptosis. Looking to, he developed right third nerve palsy, and he was improved. He has improved so much. But when you look at him now, he has residual ptosis. When you asked him to abduct his eye to look to the right, you notice his palpebral fissure is narrowed. And when he looks to a deduction, he goes to the left with a deduction. When he uses media rectus, you see that the palpebral fissure widens so much. So what's going on? Why is this happening? For this strange phenomenon, this is what we call third nerve aberration or section. This takes place only in compressive lesions. Leave him alone. I will do imaging for him, MRI, and you will almost always find mass hiding somewhere within the brain. So this is the message. Aberrant regeneration of third nerve, always do imaging. We're talking about ptosis. Once you have decided that this is a pure eyelid problem, everything is fine, and you want to consider surgery for him, you have to decide based on the function whether you'll do a sling for him or you will do elevator resection.
Dr. Samer, we have a voice problem. Every now and then the mic is not working.
Okay, okay. Now, is it better now?
This is good, but sometimes we don't hear.
Air condition هو بظهري عشان هيك لما يطلع صوت. معلش, I will stop the air condition. Sorry for this.
Okay.
When you feel that the elevator function is poor, then you have to do brow suspension based on the elevator function. And this is what we do. This is before and after the brow suspension, what we call as sling. Okay. The material for brow suspension is fascia lata, mersaline mesh, silicone rod, proline mesh. Ideal material for brow suspension. Okay. Now this is the pull. 30 seconds.
Dr. Samer, I think we need to do something with the mic every now and then.
Okay. 1 minute. 1 minute. Just 1 minute. Just 1 minute.
Can you show us the results of the poll? The voice is good now.
Better, huh?
Yeah.
Okay, excellent, excellent. The answer is correct. This is perfect answer. The ideal material, yes, is fascia lata. Whenever you use any of these other materials, the lid height keeps going down with time. So the ideal material is fascia lata because it's integrable and it is something which lasts forever. I usually correlate with my orthopedic colleague to take the fascia lata, small incision in the lateral thigh, and he goes to the to the fascia lata. This is their work on daily basis. He gives me strips of fascia lata, and we place them as the sling material, and that's it. We never get any recurrences. While the other synthetic materials, all of them keep going down with time. How's the voice, Dr. Ibrahim?
Good, very good.
Excellent, thank you. Okay, now if the elevator function is fine, more than 5 millimeter or so, then you go to the traditional levator resection. So this is how we decide which procedure to choose. Levator function, the normal levator function, then we do levator advancement or section, pre and before. Moving to congenital ptosis. Now, congenital ptosis is a frequent problem, but unfortunately, you have to be very cautious. This is unlike the adult ptosis. Here, the concern is amblyopia. You have to send him to a pediatric ophthalmologist to assess his vision, to assess that his motility is fine, to assess his refraction. There's no joke. This is the critical period. Half of his upper visual field is obscured, and he might be excellent candidate for amblyopia. And when by the age of 6 or 7, when he visits the oculoplastic surgeon, it's already too late to treat his visual problem. So here we have to take excellent care of his vision. Moving to lid masses, eyelid masses. Eyelid masses also is a frequent problem. You should be cautious because you don't want to miss a serious tumor or so by giving him just antibiotic cream without knowing what's going on. You have to consider that this lesion, which is a basal cell carcinoma, might turn into this huge, terrible basal cell carcinoma. If the patient visited me here, I will resect this much and close it directly maybe. Here I will have to chop off half his orbit to make a possible cure. So we never treat eyelid masses, especially recent masses, without taking histopathology at least. I take a chip of this, a small wedge. I send it to histopathology. I know what I'm dealing with. I don't give him cream and the patient disappears and then we end up in this catastrophe. In patients with multi-injured patients, we have to always organize priorities correctly. We ophthalmologists have to be really safe, and we don't end in an awkward situation. So always multi-injured patients, rule out life-threatening problem, abdominal injury, head injury, chest injury. Then look for the globe integrity, because the patient might be having ruptured globe or so. And you are sending, the oculoplastic surgeon is the last one to intervene here. Okay, The patient has a lid laceration. You should always, especially when the eyelid laceration is close to the medial canthal area, you should always consider, does he have canalicular laceration or not? You should ask yourself this question. You have to always think, you might even take him to operating room to make sure that does he have this or not. Because if you discover that he has canalicular lesions and let's say 1 month or 2 months later, he lost his golden opportunity, this gentleman, of having a therapy, a proper therapeutic approach. So, question number 5. In canalicular injury repair, the best solution would be good closure with nice approximation of cut edges alone, or this excellent closure plus monocanaliclar intubation, or with bicanaliclar intubation, or with pigtail prop intubation. So what's the choice here? When you have a canalicular injury, the best approach is direct approximation, nice approximation of caniculi, or this approximation plus monocanaliclar, bicanaliclar, or pigtail prop intubation. So let's see the answers, please. Answers, please.
You did not mention.
Is it both or one caniculus?
Well, now the answer is done. I should have mentioned, yes, that's a monocanacular injury. Yes, thank you.
Right.
Usually, it's the common
good.
thing is the single caniculus, but yes, you're right. To be more precise, you have to say whether it's bicanicular or monocanacular injury. So the answer was correct. If you do direct closure of cut edges alone, probably will end with severe scarring. You have, if we're talking, as Dr. Bray mentioned, one canicular injury, you have to place a tube and close the lids nicely around it. You should never do bicanicular intubation or pigtail propping for patients with single canicular injury. Pigtail prop, I think, is no more available, thanks God. Moving to another, as I mentioned, the talk here is about variety of topics in oculoplastic surgery. Moving to another common problem, facial palsy. One of the most dangerous things is to treat all patients with facial palsy as cases of Bell's palsy. Bell's palsy is the idiopathic facial palsy, which is the commonest cause of facial palsy, but it is a diagnosis of exclusion. You have to make sure that everything else is fine, and then you say this is Bell's palsy. You cannot classify every patient with facial palsy, lower motor neuron facial palsy, as Bell's palsy, till you make sure that he doesn't have any of these other things: acute otitis media, herpes zoster of the ear, malignancies of parotid, brain acoustic neuromas, trauma to facial nerve, sarcoidosis. All of these can cause facial palsy. And also in facial palsy, we have to take care of the cornea. The organ at risk in the facial palsy is the eye. Also, there's another disease where the organ at risk is the eye, and the ophthalmologist has to play the vital role is idiopathic intracranial hypertension. So in these two entities, the organ at risk is the eye. You see this teamwork, facial palsy, ENT doctors, plastic surgeons, maxillofacial, long list of surgeons and physicians are involved in the management. So what's the organ at risk? It's the eye. So ophthalmologists have to be the key player here. Never delay tarsorrhaphy. You can do stitch tarsorrhaphy even in the clinic, because when you have corneal exposure, I have seen lost corneas recently because of facial palsy. This should not happen in the year 2020 or 2021, probably, because in 2020 it seems that we are not going to do any work. So in the year 2021, we should not lose any corneas. Okay. This gentleman was visiting me. He was having a long-standing facial palsy. He was referred to take care of his eye. He was under the care of some other specialty. When I checked his parotid area, I discovered all this fullness. So I referred him to the plastic surgeons who took a biopsy to return as squamous cell carcinoma of the parotid, causing his facial palsy. He was treated for many months as Bell's palsy. Or he might be having some more serious problem. Question number 6. The lesion causing facial palsy here is located where? This is the lesion, in fact, in the brain. This lesion, where is it located? Is this sphenopalatine angle, or the cerebellopontine angle, or brainstem, or clivus? Pull, please. This lesion, which is causing a very serious facial palsy, is located where? Answers, please. Excellent, beautiful. Yes, it is corrected in the CP angle, cerebellopontine angle. This is the pons, and this is the cerebellum. So it's the angle here, CP angle. This is the posterior. So you have to do this job. Mass and the nicely. Most of the time we can put the facial nerve. Moving to lacrimal diseases. So the first diseases, I talk about some of the most lacrimal diseases that I'm talking about. The best practice I feel in such cases. One of the commonest congenital lacrimal obstruction, which is normal thing in 5 panels. It's a common disease, 5%. Healthy children.
الصوت كان فيه بس مش واضح.
5%
الجزء آخر 20 ثانية ما كانش واضح.
Okay. Now tell me again, please, if is it better now, Ibrahim?
It is now better, but it goes and comes.
Okay,
So the last 30 seconds, most of the audience did not hear well.
All right. I'm sorry about that. Okay. Now we'll move into the lacrimal disease, congenital nasolacrimal duct disease. Congenital nasolacrimal duct obstruction is a frequent problem. In fact, 5% of people, healthy children, are born with congenital nasolacrimal duct obstruction. The ideal thing, as we all know, is to do the massage, but you have to teach the mother how to do the massage correctly. Most of the time, I find the mothers do massage correctly. Good massage will give you 95% resolution of the problem. If this persists despite massage, then at the age of 1 year, I will do propping. If the patient presents later, or he has done previously a propping which has failed, then I will consider the golden standard of treatment, which is lacrimal intubation. Lacrimal intubation has changed the equation because now we have beautiful monocalcular tubes, very easy to insert, takes extra 2-3 minutes. Once you finish your propping, you gush the dye in the nose, and the anesthetist tells you that the dye has come, so you have opened the nasolacrimal duct. If you leave him without a tube, the risk is that on that same night, the nasolacrimal duct will block again, and this was a waste of money and effort and the general anesthesia for the kid. So place this monocalcular tube. There is also improvement on this with the even in beautiful tools. Ideal thing, place it, and this is how it looks from the nose, and you are done. I have rarely seen a patient who has reblockage after the intubation. Going to punctal stenosis, this is a very common problem, punctal stenosis. The most dangerous thing for me in punctal stenosis is that people keep dilating the puncti and keep doing the syringing, and they cause iatrogenic damage, which we fail to solve once the patient is referred to us. So if you did the punctal dilatation and you did the syringing and you found the patent system and give him some antibiotic with steroid for a couple of weeks, if he doesn't improve, then you have to go to the next step. Don't do and resyringing. That's malpractice. That's a destructive procedure. There is nothing in medicine like this. So you either do a snip procedure or place the golden standard, which is a perforated punctal plug, which is it's done in the clinic and it solves the problem most of the time. But don't syringe again and dilate again. This is malpractice. Dactylocystitis is a common problem. When you see a lady like this, there is almost no role for oral antibiotics alone. She needs parenteral injection. You have to give her either IV or intramuscular injections. The injection of choice for me is lincomycin because it's a beautiful antibiotic, cheap antibiotic, given intramuscularly twice a day, and it covers the gram-positive and the gram-negative and anaerobes. So I give them lincomycin for 3-4 days, and then give them amoxiclav or augmentin or anything like that till they resolve the cystitis. Then I plan them for DCR. This lady will need DCR, no doubt. Once this is resolved, give her a couple of months. If you don't do DCR, she will recur with the same appearance. So this needs DCR. Going to this child with swelling here in the medial canthal area, and he was diagnosed as dactylocystitis. But the observation which has been missed is that the swelling is not under the medial canthal ligament. The swelling is above the medial canthal ligament. So this is not a dactylocystitis or mucocele. This is an cephalocele. This part of the brain is inside here. You should never, anything above the medial canthal ligament is not a dactylocystitis or mucocele. Always image the patient. Moving to orbital diseases, the frequent malpractice is performing MRI before performing CT scan. The investigation of choice in the orbit is CT scan with contrast. CT scan is a very cheap, cheaper option, less difficult because the patient doesn't have to go within a tunnel and it doesn't have to spend 45 minutes within that tunnel. So he just 15 minutes faster and cheaper. And gets much more information for us.
The voice again, Dr. Samir.
The voice.
Okay. That's good.
Okay, thank you. So we don't go to MRI before doing CT scan. We do MRI in certain cases when we are talking about the apex problem. Has a soft tissue of the orbit has a problem. We can make MRI. Most of the time, CT scan will do fast. We can say and we will give you guidelines of if you want to operate. Thyroid disease is one of the commonest complications in clinics. This is the only endocrinologist to lower his thyroid function to make sure that his autoantibodies are fine and his sexual antibody twisted. We are not talking about hormonal problem alone. This is an immunological problem, in fact. So always request on autoantibodies. The endocrinologist will do the work most of the time, and then consider the steroid in selective cases. And steroids are not given in oral therapy. It has to be given in the protocol, the standard international protocol, which is the injectable steroid. You have to injection of steroid once every week for 6 weeks. This is the international protocol. You give steroids only in selective cases. In fact, not every thyroid ophthalmopathy will need steroids, because remember, steroids are very serious medication and has lots of side effects. You have to tailor which patient deserves steroids. In active thyroid eye disease, like the previous gentleman, you can see the signs of inflammation. Okay, he has proptosis, but proptosis with quiet orbits will not benefit from steroids. You have to have signs of inflammation, hotness, redness, swelling, pain, or if there is optic nerve compression, then you have to give steroids. Or if you are planning a radioactive iodine therapy for the thyroid, you have to protect the patient orbit by giving him oral steroids. In thyroid eye disease, this is the normal orbit, and this is the thyroid orbitopathy. You can see the muscles have got pregnant, and you can see how crowded the orbit here, and it's compressing the optic nerve. You have to consider decompression. So you cannot treat surgically indicated cases medically. Moving to another problem, this child has this visible mass. When he was born, there were only these strawberry-like things, discoloration, which kept increasing in size. And he visited his ophthalmologist. So this is most probably, we're talking about capillary hemangioma. The investigation of choice, this is question number 7. Investigation of choice in capillary hemangioma is ultrasound, MRI with contrast, CT with contrast, or clinical exam alone. I will repeat the question. In capillary hemangioma, the diagnostic tool you request is ultrasound of the orbit, MRI with contrast, CT with contrast, or clinical exam alone. Let's see the answers, please.
For Simon, it seems there's a connection issue. The voice goes and comes every now and then. Probably it's the internet connection, I think. It's not the mic. But it's okay now. It's okay now.
I'm very sorry, Dr. Ibrahim. Wallah, this is the strongest Wi-Fi I have. I'm sorry about that.
Okay, that's okay.
Okay, thank you. So, beautiful answer. Yes, we don't do imaging for kids like this. When you have to do imaging, this intervention for a child like this one, you have to put him to sleep. General anesthesia to do MRI or CT. Why would you do this? This is a book picture of capillary hemangioma. So just there's a clinical exam. Listen to the mother and the father. They will show you the images, how it was growing. So there's a clinical exam. If you request some sort of imaging here, MRI might be safer for the kids, and you will have this pool of dye. This is MRI with contrast, pool of dye. This is the capillary hemangioma. Moving to another subject, also very important, orbital cellulitis. This is a life-threatening problem. There's no joke here. This child, when she came to me, she had almost imminent cavernous sinus thrombosis. She was treated with empirical IV antibiotics, some of the simple antibiotics for many days, and she didn't improve. This is her MRI when she was done, although there's not an investigation of choice, but they did MRI. So there's ethmoiditis with severe, as you can see, orbital cellulitis with possible abscess. So this needs a drainage. There's no role for antibiotic anymore. So we went with the NT. This is the NT incision. They call it Haworth incision. We call it Lynch incision. This is not a very beautiful incision because it leaves a scar, in fact. So we drained her sinus and her orbit, and she improved dramatically. Another vital problem on the orbital masses, any new orbital growth should be considered malignant till proved otherwise. In old age or in the middle age, you should always keep in mind this possibility, lymphoma. It can present anywhere within the orbit, within the lacrimal gland, and it always comes like salmon patches, and it's fleshy. You just take a simple incisional biopsy and send it to a good pathologist who will give you the answer. Many a times, the results return as lymphoid hyperplasia, and when you refer it to another pathologist, like the King Hussein Cancer Center, they have excellent pathologists. They change the diagnosis into mild lymphoma. This patient will need radiation, in fact. Nothing will help other than radiation. So proper histopathology, you have to rely on a good histopathologist. There's another lymphoma, intraconal mass. I performed the biopsy and returned as mild lymphoma. In children, any new growth should be considered malignant till proved otherwise. Don't delay the biopsy. I mean, why would you think there's a hemangioma? This genital child is 7 years old of age, brought to you 2 weeks history of progressive swelling. I almost never performed biopsy for such cases without returning as a malignancy. It's always rhabdomyosarcoma or lymphoma or anything like this. So always consider malignancy in such cases. One of the common lacrimal gland malignancies is adenoid cystic carcinoma. This is a serious problem. There's no joke. You can see it can destroy the bone and invade the brain. So there's really no joke. When you have a lacrimal gland mass, so you have to consider referring the patient to the proper orbital surgeon, because he might need serious intervention before he dies, in fact. Usually there is a role for intraarterial chemotherapy to debulk the tumor and then do excision of the mass with radiation. So there's no joke. Moving to the favorite topic of Orchidia is talking about dry eye. So I will talk about dry eye. Dry eye, yes, there's a role for good lubricants most of the time. Give him lubrication, daytime, nighttime. Choose the lubricant of choice. But when this lubricant is not giving enough resolution of his problem, consider more advanced step, doing the silicone plug to give him a more lasting relief. Plug one of the puncti along with the lubrication. Lubricant will be more effective now, as it's not going to disappear within minutes or seconds from the tear film. Lubricant will stay because something is blocking its way. Even you can consider permanent occlusion in miserable dry eye cases, like in xerophthalmia with Sjogren syndrome, or in graft versus host diseases. You can consider permanent occlusion. Moving to the last topic, conjunctival and socket. Always when doing evisceration or inoculation, you have to use implant. There's no role for evisceration or inoculation without use of product size implant. This is one of the miserable cases I've seen early in my oculoplastic practice. She had inoculation without implant and with irradiation, and you can see how miserable her socket is, phimosis, and there's no role of surgery for me. In fact, we sent her for a maxillofacial prosthesis. How was the voice, Dr. Ibrahim?
Good.
Good, thank you. So this is her 3D scan, because she was a child when she developed this problem and no orbital implant was inserted. She developed what we call as orbital hypoplasia. This is a normal sized orbit, and this is her left orbit. So you have to use the material, you have to use the orbital implant. I don't use these hydroxyapatites except in inoculation. I do always silicone ball in evisceration, and I place a good implant size. You cannot use 14 or 16 implants. These are placebo implants. You have to use 18, 20, because you want to replace the volume. Otherwise, you will develop this miserable problem, which is post-inoculation socket syndrome. The socket will be miserable, sunken sulcus, fornices are lost, and it's a mess. So you have to place a good-sized implant and solve the problem from the roots. We can now modify our classical evisceration, because when you do the classical evisceration, you might really be, the cavity left inside is a 14, 16 size implant. So we do sclerotomies. There are many ways of releasing sclerotomy to expand our socket and place a proper sized ball, 18 or 20. Using conformer is must. You cannot leave a socket without conformer even overnight. You have to worry when the socket is without conformer. You might develop conjunctival scarring with fornical loss, and then that's a terrible complication. You will need a conjunctival graft for that. Congenital anophthalmia is a rare problem thanks to the new modalities, the hydrogel hemisphere expanders. These are just like the games. The boys, the kids have toys. When they place them in the toilet and in the water, it fills within time, 48 hours. This small implant develops into this large implant. So slowly you are expanding the socket and preparing the microphthalmic anophthalmic socket for the ideal prosthesis. Last topic is conjunctival growth. Again, any conjunctival growth, recent growth, you have to be suspicious. Don't say this is pterygium. You see this ugly growth, terribly vascular, irregular, fluffy, with also leukoplakic changes. This cannot be pterygium. This is a tumor. You can do incisional biopsy if you like, or you can refer him to an oculoplastic surgeon or to an ophthalmic oncologist to do the proper thing, which is removing the whole mass with clearing of the cornea. This is very simple to remove from the cornea, in fact. It's much easier than pterygium because it's just sitting on the cornea. You just slough it with the blade 15 and it starts coming away. Use alcohol to treat the limbus, and then cryotherapy to the bed of the conjunctival tumor and edges. This is no joke. This is a life-threatening problem. So that's all what I had to say, and I thank you for your listening and apologize for the voice problem. Dr. Ibrahim.
Thank you, Dr. Samer, for this interesting presentation as usual. While we are taking the written questions, I'll ask Tariq to unmute those who are raising their hands if there are any. So questions from the audience. Question number 1 from Dr. Ahmed Ali. If Dr. Ahmed Ali is there, he can unmute himself and ask the question to Dr. Samer.
Thank you, Dr. Sandberg, for this interesting lecture.
Thank you, Dr. Mohammed.
My question is about third nerve palsy, painful third nerve palsy.
Yes.
What do you mean by pain? Is it headache or ocular pain?
It's in fact, the question here is for Dr. Ibrahim. Dr. Ahmed, اسمح لي, please.
Yes.
I want Dr. Ibrahim. We have a distinguished neuroophthalmologist. While he's sitting here, I cannot answer. If he wasn't here, I would have answered. Dr. Ibrahim.
Okay.
Yes, it is just pain. It is either in the eye, retroorbital, or simply headache. So any painful third nerve palsy, you can either it is eye pain, retroorbital, you can consider it as a painful third nerve palsy. Dr. Ahmed, you have another question, right?
There is another question for Dr. Sandberg. Can
Yes,
upper
please.
canalicular laceration
Yes.
without intubation?
I will always consider the canaliculus as a vital structure, Dr. Ahmed.
Yes.
And the whole theory is that the lower canaliculus is the only important one. This is obsolete, in fact. Both canaliculi are vital. So yes, you have to address it with proper management, with intubation. You never know if the lower lid develops injury later in life, for example, God forbids. What will you do for him? I will always treat both of them as a very precious tissue. Yes, I will intubate. Thank you for the question.
Thank you very much.
Dr. Haider, if you hear us, you have a question, you can unmute yourself if you want to ask the question. Haider 965. So the question was about management of dacrocystitis in infants.
Again, Dr. Ibrahim, management dacrocystitis?
Infancy.
In infancy. Yes, okay. You see, once you have developed dacrocystitis, the child with a nasolacrimal duct obstruction, once he develops dacrocystitis, this is a clear indication for early surgery. I will not send back the mother home until I do massage. Once he developed dactylocystitis, I will probe him as soon as possible. I will consider whether to do intubation or DCR according to his age. This child, for example, he has the congenital amniotic. Congenital amniotic is a surgical problem. Massage will almost never help the child, so I will do surgery for him, propping soon. Dactylocystitis in children, yes, is a dilemma. We usually avoid doing DCR before the age of 3 years or so, because the bone is not very well developed, and the osteotomy will might disfigure the child. In fact, you might consider endoscopic DCR for these kids in particular to decrease the amount of bone removal, but he will need surgery. Yes, and this is a challenging. This is an excellent question.
Dr. Samir Al-Jayusi, if you can hear us, you can unmute yourself and ask your question.
Regarding hemangioma in children, CT scan
Yes.
in black children, I think we need CT scan because we have cases were not clear that it's hemangioma.
دكتور سمير, sincerely, الوضع كالآتي. أنت you are the clinician, you are the decision maker. If you feel that the history and the exam doesn't go with capillary hemangioma, you have all the right to image him. MRI would be better for children because you don't want them to expose them to a huge amount of radiation. But if the clinical story, as I told you, this strawberry nevi here, strawberry reddish hemangioma.
In black children.
I don't know much really about what difference makes being black, really. I don't know.
Because the color sometimes doesn't appear.
I mean, we don't have lots of black people in Jordan. In fact, I don't know much about this really, but imaging is not a harmful tool, but I'm trying to save the dollars and to save the anesthesia for the kid, in fact, and the torture for the family. It's not a harmful thing, but we're trying to do a good practice of medicine.
Thank you.
Thank you, Dr. Samir.
Dr. Ajwad, do you have a question? You can unmute yourself. Ajwad raising his hand.
No, I don't have. Thank you.
So basically, one comment on that. If I feel that there is an orbital component or a tense orbit, and I believe that the hemangioma is compressing with the optic nerve, for the sake of diagnosis, for the sake of treatment and follow-up, probably I will need to do MRI for the kid.
Yes, yes. Agree. Agree.
All right. So, Dr. Asma, do you want to ask your question? You can unmute yourself if you are still there.
Yes, how are you, Dr. Asma? Dr. Ibrahim.
Dr. Asma. Alan.
Thank you.
Yeah, I just want to ask about lacrimal gland swelling. You go for biopsy directly or you do imaging first? Because here in Canada, I noticed that the practice, they go for biopsy directly. They don't go for imaging.
Excellent. Dr. Asma is doing a fellowship in Canada with one of the pioneer oculoplastic surgeons there, Dr. Khan, Yasser Khan, my friend, in fact. Okay, Dr. Asma, in fact, as I said, you have to always judge the story. If you feel that this is dacryoadenitis or possibly lymphoma, then go ahead with your biopsy. Most of the time I do this in the clinic, in fact, because I do the biopsy transconjunctivally. I do it from the fornix and under local anesthesia. Simply, I take the representative lacrimal glandules, and most of the time I get the pathology. If you feel that this is not a straightforward, simple lacrimal gland problem, then you have always to do imaging. You know, as we learn in medicine, we don't want any surprises. I don't want you to end in a bleeding in your clinic or in the minor operating room in a catastrophic bleeding because this is a terribly vascular mass or there's a ruptured dermoid or etc. So you have to be cautious and consider each patient individually and assess him separately.
Okay, thank you, Dr.
Thank you,
Samer.
Asma. Thank you.
We have other questions from Dr. Magda Al-Sayed. Dr. Magda, if you are here, you can unmute yourself and ask directly to Dr. Samer. Dr. Magda Al-Sayed. Her question is, how much and how long would you give steroids in thyroid eye disease?
Yes, excellent question. Excellent question. Okay, in thyroid eye disease, I would really give him the ideal, it's UGOGO, they call it UGOGO protocol. A European orbital surgery, they made the recommendation. You have to give them, you control by anti-TSH receptor antibody. This is something vital. It's not a hormonal problem. Remember, thyroid ophthalmopathy is not as we used to think. It's just a simple hormonal problem. No, this is an immunological problem. The body has recognized the orbit as a thyroid and it is attacking it because antigenically and immunologically the orbital tissue, orbital fat and muscles, they share the antigenic characters with the thyroid. So the body thinks that this is part of the thyroid, so it is attacking the orbit. So you cannot treat the thyroid ophthalmopathy without cutting this link, either by doing thyroidectomy, which is the ideal choice in any thyroid problem, better than radioactive iodine, definitely. And then you can give him steroids and control his anti-TSH receptor antibody. Steroids, you give him once a week for 6 weeks. This is the protocol. You give him 4.5 grams. If he's an adult, you give him 4.5 grams or so. Divide them once a week. And the beauty of these IV steroids, they don't go give side effects just like oral steroids. They don't increase the weight. They don't increase the water retention. They have very little side effects, and they have much more potent effect against the thyroid inflammatory problem.
Dr. Osama Abu Khalid, do you want to ask a question? It is about the same thing, about congestive orbitopathy. If you are there, you can unmute yourself. So it is about the same thing, treatment for orbital thyroid congestive orbitopathy.
Yeah, once the thyroid inflammatory signs are gone and the anti-TSH receptor is lowered and the hormonal status is controlled, I will consider definitive surgery in the form of either decompression or eyelid disease or strabismus in case there is myopathy. Once the immunologically is stable and endocrinologically is stable, I will consider permanent solutions. The patient who needs decompression, don't try to escape from him. He will never be in good shape without decompressing him. The ideal thing is, as I said in one of my talks, this corona crisis, is balanced decompression. We do, along with the ENT surgeon, ENT decompresses the medial wall, removes for us the whole lamina papyracea, and the fat will be floating within the nose, and I remove this lateral bone, and in this way you have really decompressed the orbit. You have given a future for this orbit, which is terribly crowded. You will keep giving him steroids and immunotherapy and etc. for long periods. This will never be relieved without relieving the term used, Dr. Osama mentioned correctly, congestive. This is a congested orbit, you have to relieve it.
We have two questions from Dr. Mahmoud Mursi. If you are there, you can unmute yourself and ask your questions. Mahmoud Mursi. If you are not there, I can ask the question. What is the role of statins in thyroid ophthalmopathy?
Statins. I'm not sure that I know that there is a role for statins. Statins I know for lipid problems. But you can use selenium. This is a material which is يعني مكمل غذائي بعتبروه selenium. You can use it, yes. You can use anti TNF, tumor necrosis factor now. Biologics are starting to play a role. There are drops, even they have developed drops, anti-insulin growth factor drops, which is hoping to give some future. I don't know much that there's statin role here.
Statins. What about role of systemic beta blockers in capillary hemangioma?
Yes, this is a very well proved modality, Dr. Ibrahim. As you know, beta blockers for capillary hemangioma, either systemic or topical even. Give them timolol drops along with systemic beta blockers. Along with myself, I still give the steroid injection. I find it the perfect solution because it works quickly and it gives excellent resolution with minimal morbidity.
Right. I think we don't have any more questions. Thank you, Dr. Samer, for this interesting and thorough presentation as usual.
Thank you, Dr. Ibrahim.
كل عام وأنتم بخير للجميع الحاضرين إن شاء الله.
شكرا دكتور إبراهيم. شكرا أوركيديا. شكرا جمعية طب العيون. السلام عليكم. كل عام وأنتم بخير.
شكرا لكم. شكرا. مع السلامة.